Sleep is very important. It encompasses 1/3 of our life. The significance of it stands without reason. Without it, we cease to exist. With it, we function the best. Whenever sleep eludes us, it impairs our ability to function. And that includes alertness, concentration, memory, interpersonal relationship. And disorders that affect sleep, such as depression, such as chronic fatigue syndrome, fibromyalgia, have an impairment, a significant impairment in functioning during the day. Treating these conditions are essential as the patient as a whole, as opposed to just trying to, if you will, nick and pick the small segments, just trying to treat the pain and or the mood disorder and think that the sleep is going to improve. It has to be addressed specifically as part of, if you will, your diagnostic team. Often chronic fatigue, fibromyalgia entails multiple specialists working together to optimize the patient outcome and treatment options. So what are the most common symptoms that one sees with patients with either fibromyalgia or chronic fatigue syndrome? I think by far our major complaint is insomnia. And insomnia is defined as difficulty getting to sleep or staying asleep. That's a very common feature, and many reasons or causes of insomnia in these particular patient types. For example, these could be associated with the medications that are used to treat the disorder that can cause difficulty with either getting or staying asleep. Disorders of excessive napping just prior to bedtime may offset the timing and schedule of sleep. Those are called the homeostatic or the circadian misalignment of the timing of sleep. That can result in difficulty either getting or staying asleep. So insomnia complaints is common. Patients with major pain as a feature of their symptomatology have disruption in their sleep. As you can imagine, trying to turn in bed, as we average anywhere from 8 to 16 times a night, tossing in bed, results in either joint pain or discomfort. Any disorders of pain will cause an awakening at night. And we have understood and realized that disruption in sleep at night results in not only insomnia complaints, but increasing pain during the day. That is, lowers the pain threshold. A counterpart of insomnia is complaints of fatigue or excessive daytime sleepiness. That is, that these individuals awaken in the morning and never feel refreshed and they're tired, but a large portion of them are also sleepy. A lot of the patients have difficulty in describing whether they're fatigued and or sleepy, and quite frankly, often patients have both. Once again, multiple causes of the complaints of daytime sleepiness could be anywhere from lack of sleep at night, which results in fatigue and sleepiness during the day. Medications that are used to treat either chronic pain or disorder itself can cause fatigue and tiredness during the day. Mood disorders are very common in patients with chronic fatigue and fibromyalgia. Mood disorders being depression, major depression illnesses. Medications to treat those conditions can cause fatigue and somnolence as well. And then the part that we still have a large educational understanding of the disorder itself is that the mechanism by which the brain restores an individual's sleep that results in meaningful wakefulness and restorative sleep the subsequent day, the disease itself must have some sort of impact on the patient's sleep quality. There are many patients that I study in our sleep center here for evaluation and to rule out other conditions that are associated with fatigue, such as sleep apnea, periodic illuminative sleep, and other conditions. Often their sleep studies are normal, at least superficially. But when an individual looks at the sleep physiology in those individuals, there seems to be an abnormality in the architecture and the distribution of sleep. Often those individuals are missing what is defined as the deep sleep. In our specialty, we define those as slow wave sleep. A newborn, half their sleep is slow wave sleep. So slow wave sleep has a very important impact in development, and that is the growth hormone. Growth hormone, of course, is very important not only in a not only a sense of development, tissues, etc., but also a sense of well-being. It's our restorative hormone, if you will. One of the aging process is marked diminution of growth hormone as we get older. It is recognized that these patients with fibromyalgia chronic fatigue syndrome that are in the age category where they should still have adequate amount of slow-wave sleep, that their sleep studies demonstrates a marked diminution or distorted slow-wave sleep, or perhaps that might be one of the physiologic clues of this abnormality of not feeling rested and fatigued. There has been experiments dating back to the 70s and 80s. Dr. Modolsky described medical students, which is the perfect candidate to do experiments on, especially in sleep. They volunteer relatively easy. He deprived them of this deep sleep, and within a period of 2 weeks, these individuals could not be differentiated from fibromyalgia with a marked component of fatigue. He postulated that slow-wave sleep is a very important part in the pathophysiology, that is the mechanism by which perhaps fibromyalgia is developed. We also know that the immune system is reinforced, if you will, by these stages of sleep, especially stage 2, we define now as N2, and stage 3, which is the slow-wave sleep. So perhaps this gives us once again a window of opportunity to understand the mechanism, how sleep disorders, if you will, coexist and mingle with immune disorders developing chronic fatigue syndrome and or fibromyalgia. So I divide the realm of sleep complaints in chronic fatigue fibromyalgia patients into disorders of the night, be it snoring, involuntary limb movements, that's called periodic movement of sleep, or multiple awakenings at night with insomnia, or disorders of diurnal disorders, that is inability to stay asleep, exhausting fatigue. Once again, most of the patients have both. Once defining both of these, then we ascertain, well, what is the significance, the impact of these complaints on the patient's functionality? If indeed the condition of either the night or condition during the day that impairs function night or day is impairing their ability to function on a chronic basis, then I feel at that point, of course, if anything, bring this up to your physician and at least seek help, consultation, and assistance. When the impairment of the night and or the ability to maintain wakefulness during the day or the fatigue is overwhelming, it's a good idea for an initial consultation for an opinion and an evaluation. Often simply just by assessing the patient's history and more importantly asking the bed partner what their observations are at night may give the physician, especially the sleep physician, clues on perhaps other coexisting sleep disorders. We know that sleep apnea is very common among the general population of adults. And so we understand that there is a relationship of distorted sleep and not feeling rested during the day in these patients with sleep apnea. Who's to say that fibromyalgia or chronic fatigue patients do not have comorbid, that is coexisting sleep apnea as well? Why is it important to diagnose this, and why should you treat it over let's say chronic fatigue syndrome? Because the treatment of conditions such as sleep apnea, restless leg syndrome, or periodic movement of sleep are relatively simple, with expected outcome, with a good efficacy, and may play a large impact in improving minor changes in the patient's quality of sleep that results in improvement in daytime function. These changes are huge for the patient's outcome. There's perhaps some misconception or perhaps anxiety about a diagnostic test that we use in our field to assist us in the diagnosis of certain sleep disorders. And often patients with chronic fatigue syndrome and fibromyalgia require additional testing. In the sleep study are defined as different types. There is the nocturnal, which means nighttime sleep study. And then there is the multiple NAT test, which assesses daytime sleep. And so depending on what your sleep physician is inquiring or interested in assessing or evaluating or excluding because you gave them a certain history that provided perhaps an insight into other conditions that are contributing to your fatigue or sleep disturbance, then the appropriate test is ordered. Simply put, the night sleep study, which is called a nocturnal polysomnogram, is an evaluation of your night sleep physiology, breathing physiology, electrocardiography, oxygen, and limb movements. It's a test to evaluate if there's any abnormalities that encompasses either disruption of sleep at night or something that's interrupting your sleep, such as sleep apnea, such as periodic limb movement of sleep, that can contribute to not feeling rested that is not obvious to either to your observer, your bed partner, or the patient themselves. Often in our sleep center, patients come here with their spouse, and it is the spouse that provides the history, the insight of there's something else going on besides the patient not feeling rested. And at night, perhaps they might either talk in their sleep or twitch or snore or gasp or hold their breath. Having said that, the test, the night sleep test, the nocturnal polysomnogram, is crucial in ascertaining perhaps an insight into the patient's cause. So it is not a subjective test, but rather objective test. You cannot fake or you cannot subjectively interfere with a sleep study unless you take stimulants, of course, prior to bedtime, and then the objective outcome is you did not sleep. Does that happen in a sleep center? Of course it can, but usually if we align their sleep study with their schedule of sleep, for the most part is relatively easy to capture a component of their sleep that gives us a diagnosis that we can at least grasp and find a better mechanism or approach to their sleep complaint. The environment in most sleep centers nowadays are very hotel-like, comfortable, temperature is comfortable, it should be quiet, dark and cool, which incidentally that's part of the sleep hygiene, dark, quiet, and cool. There are portable sleep studies nowadays that are being done at home. These are called ambulatory sleep studies. Ambulatory sleep studies are not the standard of practice for evaluating patients with fibromyalgia and chronic fatigue syndrome. This is due basically that there's no direct observation of the patient and the patient's multiple complaints are beyond just sleep apnea. The home ambulatory study is only to evaluate sleep apnea, and that's the only indication. So therefore, ambulatory studies, I believe, if you just want to evaluate sleep apnea and you're not thinking about any other disorders, which is probably only half of the cake, if you will, of evaluating patients with fibromyalgia, chronic fatigue syndrome, have very limited use in your condition. The day test, which is called the multiple sleep latency test, or what I like to call the multiple nap trial in its basic sense, that's the day test that we use. That's the test that we use to evaluate patients with daytime sleepiness and perhaps gives us a clue in differentiating between fatigue and sleepiness. Why is that important? Why should we differentiate between fatigue and sleepiness, since often it occurs together? Well, the simple fact that might gives us a clue on the mechanism by which your symptoms are occurring, and also may give us an intervention type of either medication or other interventions that we can use to treat the patient. So the MSLT, first and foremost, was established to diagnose a condition called narcolepsy, which is a rare disorder, but nonetheless undiagnosed, and often associated with fatigue and sleepiness, misinterpreted sometimes as an individual with extensive fatigue or perhaps chronic fatigue syndrome. So part of the differential diagnosis in patients with excessive fatigue and sleepiness during the day should be narcolepsy. It's a disorder that starts usually early in life, so it's unlikely that a 65-year-old on up will present to you with symptoms of fatigue and be it narcolepsy. On the other hand, when you trace back a lot of these patients from the time their symptoms start to the time they see a physician, at least the appropriate physician understands the process, by that time, that condition would have started in the 40s, and that's kind of like in the upper range. So sometimes, again, we use the MSLT or the multiple nap test to help us give us an insight into whether it's fatigue or sleepiness. And lastly, is this a condition of narcolepsy or a narcolepsy variant? Why is that important? Because there's specific treatment and outcome, as well as recommendations for prognosis in those individuals.